and Scrutiny Committee. I'd just like to welcome the committee and particularly welcome the Health and Wellbeing board members who I can see here today. So welcome to you as well. The meeting is being live streamed, so can I ask you just to be aware of that, and also if you've got a mobile phone, can it be either switched off or in silent mode. We do have quite a long agenda today, so we will have to keep it fairly tight. So if I move you on quickly, don't be offended. We just need to get through the agenda. So I'll start with apologies for absence. We have, do you want me to read them? We've got Councillor Hardy, Councillor Humphrey, Councillor Vilcek. That's it, I think. Yeah, thank you. Minutes of the previous meeting, so minutes of the meeting held on the 5th of July have been circulated. I'd like to confirm them as a true record. May I do that?
Move acceptance.
Thank you. There was just one item on page 5, which was access to the IC. Which found page 5. If I juggle papers, I'm sorry because there's not a lot of space. We need a member to sit on the GP Access Working Group, and Councillor Nisbet will take that role as the Vice Chair. Forward plan. To note the latest forward plan of key decisions. Is there... Oh, I missed that out. Okay. I'll come back. Declarations of interest. Have any members got any interest in to declare on the agenda? No. Okay. So the forward plan. Note the forward plan for key decisions. Is there anything we need to make a particular note of? No, you've seen it. So we'll move on to our first item on the agenda. And I say, you know, the Health and Wellbeing Board particularly asked to attend for this part of the agenda. We have Pauline Fletcher, the dental community lead, and also Tom Robson and Simon Taylor, who are going to give us an update on the dentist provision in Northumberland and assurance on the arrangements for access in Berwick. Thank you.
Across the North East and North Cumbria. Oh, thank you. Forgot to press my button. I've got my two clinical colleagues here, and we're going to do a bit of a three-way presentation. And I thought it would be helpful just to recap on some of the background and context that we discussed at the last meeting that we had in February 22. So just a reminder that there isn't any formal registration within dentistry, that patients can access dental care from any NHS dental practice. And that the way dentistry is commissioned is very different from general dental practice. So we commission what's called units of dental activities. You'll hear them referred to as UDAs. And the utilisation of those UDAs are dependent on the treatment needs of the patients that present into the practice. So, for example, a routine checkup is one UDA. If you require treatments such as fillings, extractions, that's 3 UDAs. If you require something more complex, such as crowns and bridges, that's 12 UDAs. As I mentioned, dentistry is commissioned very differently from general dental practice. We don't commission private dental care, but it doesn't stop, the regulations don't stop NHS dental providers from offering private appointments alongside their NHS appointments. Where that's the case, they usually have separate appointment books with separate clinical time allocated. That's the reason why sometimes you may be offered a private appointment if they don't have any NHS appointments available. In terms of historically, so pre-COVID, so 1920, approximately 90% of our commissioned capacity was utilised. That would, on the face of it, suggest that we were reasonably meeting the needs of the local population. However, absolutely acknowledge that it's not as straightforward as that. And certainly over the last 2 years, the COVID-19 pandemic has had a significant impact on the capacity that dental practices have been able to deliver. Tom will talk a bit more about that later on. I think because of that delay in appointments and the limited number of appointments, it has meant that we have a backlog of care, and obviously patients who have higher needs than we would have had pre-COVID. So the demand for dental care is significant, not just within Northumberland, across the country. I think there is a backlog of care, and Tom will talk about some of the challenges that we've got in terms of meeting that. In terms of commissioned capacity, at the point that I did this presentation, we had 39 Nhs Dental Contracts delivering just short of 600,000 units of dental activity per year. However, you will be aware that we had a handback of the Corbridge Dental Practice, and that practice went private at the end of August. We've also had the handback of the Castlegate contract in Berwick, which is due to close at the end of September. So that, in effect, takes about 500,000 UDAs off our commissioned capacity. So in addition to general dental access, we do commission other services. So we have an urgent care service and we have appointments both in hours and out of hours where patients have been triaged as requiring clinically urgent dental care. We commission a community dental service from Northumbria Healthcare Trust, and that's the service for vulnerable patients with additional needs that can't be met by the high street practices, so patients with complex medical problems. We obviously commission orthodontic services as well as domiciliary care services. As I mentioned, we absolutely acknowledge that there are patients that are experiencing difficulties accessing dental care. And I'm going to ask Tom just to talk about some of the reasons for this before we go on to explain what actions we've taken to date and what other actions we are progressing to try and improve things.
Hello, I'm Tom Robson, one of the clinical advisors to NHS England. I also am the clinical director for NHS 111 Dental, and I actually am a part-time wholly NHS practitioner in Berwick. In terms of the pressures and challenges that surround our profession generally and specifically locally, COVID had a significant impact upon the demand and the pent-up demand and the pent-up need that has resulted in the position we find ourselves today. When COVID was first declared and in effect general dental practice closed with the exception of a network of urgent dental care centres, this was to allow confirmation with the infection protection control measures that were then put in place at that time. General dental practice then resumed a phased return to normality in July of 2020. To put it into context, in effect, there was very little NHS dental practice between April and July of 2020. There was a minimum expectation of 20% contract return from July 2020 to December 2020. And this increased to 45% in January to March 21, 60% April to September 21, 65% from September to December 21, 85% from January to March 22, and 95% between April and June 22. So it's only the expectation has only returned to 100% in July 2022. And that's largely as a result of compliance with the infection protection control measures that were in existence at the time. So we have significant pent-up demand, significant pent-up clinical need, and how that reflects in general dental practice is that patients who are in for routine screening, routine dental examinations, all now require dental radiography, all require mapping of the periodontal status. And because they haven't been in for such a long time, they generally take longer as a clinical episode than they would have done pre-COVID. The patients who have moderate need have now got higher need. The patients with high need have now got exceptionally high need. And the result is that general dental practitioners are taking about 125% of the time that they would have taken per patient episode pre-COVID. So if you're seeing 125% of the time for each patient, that impacts on the total number of patients that any individual can be seen. So even without a workforce overlaid problem, the capacity of general practice, even operating operating at 100% of its workforce pre-COVID cannot deliver 100% of the activity in terms of patient numbers seen in the current conditions because of the pent-up need and demand that exists within the population. Overlaid on that, there's a national workforce recruitment and retention problem. People of my generation, so the downstream problem, people are tending to step back from practice, step away from the health service, or consider retirement. Upstream, the new graduates that are coming through from the dental schools have been impacted by 2 years of COVID disruption, and so their capabilities have been impacted by the fact that they haven't been able to practice clinically during the final years of undergraduate education. This has been resulted in the extension of some undergraduate programs, but it certainly affects the capability of new graduates that are coming in to replace old stagers like myself and Simon. The other issue, of course, of upstream is the compulsory postgraduate education that they are embarked upon. The foundation training programs have also been impacted by COVID, and they were largely stood down during the first year of COVID, and that has resulted in significant capability problems. The capacity has impacted across the entire country, but particularly in areas of deprivation or in areas that are geographically isolated. So across Cumbria in the northeast, West Cumbria, North Northumberland are particularly impacted because of that. In addition to that, the recruitment from overseas has been impacted by the suspension of the overseas registration examination of the General Dental Council, and difficulties in actually getting people who are registered with the GDC through the performance list validation by equivalence regulations that exist to allow individual dentists or registered dentists with the General Dental Council to practice within the National Health Service. So all of these have impacted upon the capacity of the profession, both nationally and locally. There is difference in attitude between young dentists and older dentists. The young group have a different attitude to work-life balance. There's a significant feminization of the workforce. And as a result, we tend to get fewer whole-time equivalent years per graduate than we did out of people of my generation. And that impacts on the capacity of whole-time equivalent days that are deliverable by a profession that's actually increased in total numbers in recent years. In terms of the Nhs Dental Contract, as I say, we operate on a UDA framework, and that's largely changed since it was introduced in 2006. And it's been recognised for many years that this has needed to be reformed, and the responsibility for that reformation was lodged with the Department of Health, and to say it remained in some period of stasis is something of an understatement, with 7 or 8 years of piloting before they actually rejected the pilot projects. And the responsibility for that contract reform has now passed to NHS England, and they're going through a staged reform process, the first phase of which we will see in October, and that's to reflect the enhanced need of cohorts of the population with additional units of dental activity for high needs patients. And this will go to some degree to offset the problems that communities have working in areas of high need. I'll pass over to Simon.
Sorry, everyone hear me? Yes, I'm Simon Taylor. I'm the Local Dental Network Chair for Northumberland, Tyne and Wear, and I, like Tom, provide clinical advice into commissioning matters for NHS England. As Tom's already alluded to, our current dental contract for many years has been seen as really not fit for purpose. The way activity is counted works in areas of low need, but not in areas of high need. We've had initial examination or exploration of contract reform or system reform, which, as Tom has just said, have been rejected. It's now acknowledged that something has to be done, and has to be done really rather rapidly, because we're getting practitioners voting with their feet and leaving the NHS simply because they can't work under the current system. So our new measures that are coming in are to prioritise care for patients of high needs. In the past, we had four different rates of activity acknowledgement. Urgent care practices were given 1.2 UDAs, which was if someone came in with toothache and that need was addressed. If someone only had a checkup and some x-rays, they were given 1 UDA. If patients had fillings, whether that was 1 or 20, they were given 3 UDAs. And if patients needed something more complex, such as dentures or crowns, then the practice was given 12 UDAs. They're now looking at, from the 1st of October, adding some extra bands in there. So if patients need more than 3 fillings, instead of 3 UDAs, practice will get 5 UDAs. In effect, they'll be remunerated more. And if patients require something complex, such as a molar endodontic treatment, which is a root filling on one of the back teeth, which can take a significant amount of time, then there'll be 7 UDAs, is it, Tom? They'll be credited with 7 UDAs. So that they're adding extra bands in to acknowledge that more complex, more time-consuming treatment needs more remuneration. Yes, they're looking at greater flexibility into how dental funding can be used. In the past, practices had an annual contract. If that contract was not fully fulfilled, meaning if not all the units of dental activity were completed within that financial year, then the NHS would claw the money back, but the contract would still stay the same for forthcoming years. They're now looking at practices, if they have failed to fulfill their contract for 3 consecutive years, then if no agreement can be reached with that practice, NHS England can unilaterally reduce the contract to the highest performing year within the last 3 years, which means that unused funding in not a failing practice, but a practice that is struggling to deliver their activity can potentially be delivered elsewhere, subject to workforce elsewhere. They are saying that we now need to personalise recall intervals. I don't know why they've said this. This is something that's nothing new. National Institute for Clinical Excellence have said for years that we need to tailor our recall intervals, not 6 months for everybody, but appropriate to your dental needs. So for someone who's older and has a lot of fillings, it might be 6 monthly. If someone has a lot of gum problems, it might be 3 monthly. For a lot of the young people I used to treat who had no dental decay, no restorations, it's going to be 2 yearly because it's very safe to leave them 2 yearly. They're going to make it easier for practices to introduce skill mix. We've got a large reservoir of dental professionals, dental therapists, who, under the current contract, it was the belief of the providers, the dentists who were delivering the contracts, that dental therapists could only work once the patient had been examined by the dentist and then passed on to the therapist. Now, under the UDA system, this was very difficult to work out how to remunerate appropriately these people. Apparently, that's not the case. And legislation is being worked through so that therapists will, in the near future, be able to work to their full scope of practice on patients. And if a patient only needs a certain item of work, they can almost get direct access to the therapist, which a lot of people who've been sitting there and only doing half of what they can do will be able to do an awful lot more and will help with some of the backlog we have of dental decay, etc. They are introducing a requirement that all dental practices will regularly update their NHS website so that there is contemporaneous information so that patients know exactly who is taking on new NHS patients, who isn't, what services are being delivered, whether access slots are available. It's important to note that these changes aren't currently in position, but at present it's anticipated they're likely to come into position from possibly the 1st of October. I think we'll find out more about that on next Tuesday. We're all going down to a meeting in London. But this is the first step in reformation, and we have monthly meetings where we discuss with NHS England issues, and if there are any other quick wins that are deemed to be possible that will deliver value for money but also improve access for patients, then those hopefully will be fast-tracked to alleviate the pressures that the system's under.
Thanks, Simon. I'll just quickly give you a run-through of some of the measures that we've tried to date before I focus on what more we have done. So we've provided incentives for all NHS practices to prioritise patients who haven't been seen in the practice within the last 24 months. And that's to make sure that those in the greatest need are able to access dental care. Those appointments were bookable through 111, so we could make sure that the right people were getting access to those slots. We've invested in additional clinical triage within our integrated NHS 111 out-of-hours service, and that again is to focus on making sure that those in greatest need get access to the appointment availability. We've increased the investment into the dental out-of-hours services, so with effect from the 1st of October, that was a recurrent increase, and again that was aimed at getting a sustainable service for patients with urgent dental care need. We have also offered funding to practices to deliver additional clinical capacity over and above their contracted levels. Again, the focus is on urgent care. I think taking on board what Simon has said and what Tom has said about the UDAs, we have offered that additional capacity on a sessional basis. We had, unfortunately, limited take-up in Northumberland, so we only had 3 practices at that time that came forward to deliver some additional capacity. We're also very much in discussions with all of our practices to see how we can support them to maximise their clinical treatment capacity. So we're encouraging them all to maintain short notice cancellation lists, and that's to make sure that we can maximise the utilisation of their appointment slots. Unfortunately, you may be surprised to hear that patients who fail to attend is still a significant issue in dental practices. And unfortunately, if the practice is not given sufficient notice, if a patient just turns up, that in effect is a wasted appointment slot because they can't actually reallocate that. We are working with our practices. As Tom said, recruitment and retention is a significant issue. We are trying to work with our practices to see what support we can provide them to help them to become more sustainable, and particularly more sustainable in the longer term. So in relation to the contract handbacks, I want to absolutely reassure this committee that we are exploring every possible option to try and replace that capacity as quickly as possible. Unfortunately, there aren't any quick fixes, and I will tell you some of the things that we are currently exploring and where we're currently at with those. So I've spoken to all of the NHS practices in the surrounding areas of the practices that have been handed back to see if they're interested in taking on the units of dental activity on a recurrent basis. Unfortunately, none of the practices in Berwick were able to do that, but we are hopeful that we can recommission the capacity that was released from the Corbridge practice. There is a practice nearby that has indicated that they could take on some additional capacity. So we are in discussions with them to try and make that happen as quickly as possible. We've also engaged with NHS borders to understand what capacity there is north of the border in terms of Berwick, because we know that in Berwick, with the loss of the Castlegate practice, it's left us with 2 practices that we know are also experiencing recruitment and retention issues. They have mentioned that the eye-mouth practice, which is unfortunately the closest one, I believe they're also experiencing recruitment and retention issues. And unfortunately, they're not taking on any more patients at the minute, because Berwick residents are able to register with practices north of the border. There is a new practice that will be opening shortly with Kelso, and I know that they have been advertising, and I am aware that a lot of Berwick residents have asked to be put on the list to access that practice. And absolutely, we are committed to replacing that capacity in Berwick as quickly as possible, but I thought it was helpful just to explore what options were available north of the border in the interim. I've also explored and had conversations with the 2 private practices in Berwick to see if they're able to help. So we do have the facility to be able to issue emergency contracts. Unfortunately, they're not in a position to help us at the moment. They have said that they will get back to me if the position changes. We've also approached Northumbria Healthcare Trust to see if they're able to offer some additional capacity. There are some discussions ongoing. There may be some dentists who can do some additional capacity. We've even explored whether there is a facility to operate out of Berwick Hospital. Unfortunately, the dental suite in Berwick Hospital is currently not operational because of the redevelopment, but we are exploring other options to see if we can get some premises where we can set up and commission some urgent dental care access, almost like a dental access centre. But unfortunately, I'm not in a position to say I've secured that to date, but we are exploring all options. We absolutely need to go out to formal procurement for a new contract in Berwick, because I think the current providers are not able to take on reliable long-term capacity. The private providers there, unfortunately, don't feel able to deliver any NHS capacity. What we want to do, for some of the reasons that Tom and Simon alluded to, we want to make sure when we go out for that contract that we make it as attractive as possible to try and secure a new provider into the area. So we are currently out for what's called a request for information. So that's basically a notice to the wider market to say there is going to be a contract opportunity. This is what the size of that contract opportunity is, and to get some feedback about, what do we need to do? What would be attractive to stand the best chance to get a successful procurement? Because we want to make sure that when we go out, it stands the best chance of success. The closing date for that request for information is actually this Friday. So we'll be looking at our feedback very, very quickly, and then pulling together our procurement plan and going out in the quickest possible time scale. We are not resting on our laurels, because we know that access is an issue across the whole of Northumberland. So we are going to cast our net wider. We're going to see if there are any practices across Northumberland that can offer some additional capacity. I mentioned that we did it before and we got limited interest. Hopefully the position has changed for some practices. We will try and secure as much access as we possibly can, and we're commissioning that on a sessional basis to make it more attractive to the market. We're also working with our local dental network colleagues and with Health Education England, because we are keen to explore every avenue to improve workforce recruitment and retention. So we're trying to influence locally as well as nationally in terms of what the next steps of dental reform need to cover, but also in terms of, are there any quick wins to try and get more dentists into the areas of greatest need. So exploring how we can streamline the recruitment of overseas dentists. We've got a lot of proposals that we're currently trying to progress. which we hope will help, but we need to test those out. I think it's absolutely key that there needs to be further reform to the dental contract, and it's absolutely key that we need to have some traction around recruitment and retention of dentists, because our ability to commission additional capacity is constrained by having the workforce in place. So just in terms of some summaries of key points, all dental practices are open, are able to deliver the full range of treatments. However, the demand is significantly higher than pre-COVID for all of the reasons that we've talked about. Practices have got the difficult job of balancing the backlog of care with new demand, and inevitably that means delay for patients who require more routine dental treatment. We are asking practices to make sure that they prioritise into their available capacity the patients of greatest need. But it's important that if any of your residents have an urgent dental care problem, that when they ring the practice, they say up front what that dental problem is. That'll give them the best chance of the practice to be able to understand the urgency of the need for the appointment and try and make sure that they can get them booked in. If the practice is unable to offer an appointment because all of their appointment slots are being utilised, then unfortunately they will ask people to ring another dental practice or to contact 111. The 111 dental health advisors will undertake that clinical triage to ensure that those in greatest need get access to the appointment capacity that we've got. If after the clinical triage, the problem is not deemed to be clinically urgent, they will signpost patients back to NHS dental practices, and they will offer self-care advice. We're absolutely acutely aware of the challenges, particularly in the Northumberland part of the patch, but hopefully I have reassured you that we're trying everything possible to try and commission some additional capacity as quickly as possible. I wish I could have come today to say we've managed to secure that. We are still working hard on it, but unfortunately it is still a challenge because we are constrained by our ability to get providers to deliver services, and their ability to be able to do that is constrained by the workforce. Okay, I'll stop there. Happy to answer any questions.
Yes, thank you, and thank you for being, open about where we are. First of all, like I say, we are a time constraint today, so before I take any questions from the committee, the Health and Wellbeing Board members were invited here today for this issue, this item. So I'd like to take first any comments from the board that you'd like to add into this. No? You're all happy? Okay.
Now, my main observation is that there are lots of things in progress. Things are getting settled, perhaps after a while. And also, I was impressed with your reformation program. Some, reforms are going on. So I would like to wait and see how this come through, and then maybe in 6 months' time, come back and then look at everything. And then we are also modifying some of the strategies here. So it's a good time to align how your progress meets our, revision of strategies and everything. So thank you. But anyway, it was a very informative and useful program. Thank you.
Thank you. Thank you, Councillor. Councillor Watson.
To you about dentists' care capacities. Thank you. Thank you. Has that got me? Yes. Using the capacity of the dentists, my experience certainly in my neck of the woods is that the dentists have no spare capacity to start with, and they are absolutely up to over their heads anyway, so I don't see how that's going to help.
I think you're absolutely right. A lot of practices are already maximising their clinical treatment capacity with the workforce that they've got. There are some practices that are doing better than others, and it is a shifting position. So some practices might have foundation dentists that are currently coming out of their training. That might create some additional capacity. I suppose if we don't ask, we'll not find out. We are going to be shortly going out with a workforce survey to try and understand the vacancies that are out there to be able to deliver the capacity that we're commissioned, so we know where the hot spots are, and I think that'll help us in terms of our commissioning and what we need to do and where we need to target. But you are right, it is a challenging situation.
Thank you. I'll move on now to questions from the Scrutiny Committee. Councillor Hill and then Councillor Hunter.
Thank you. I've just got two quick questions. One's regarding the short-term critical issue and then one about the sort of longer-term national issue. So just so I'm clear, and Isabel will have this on a daily basis, residents coming up and saying, help, my dentist is closed, I've got, not just I'm in need of a checkup, I've got a big problem, I'm in agony. And we can sympathise with them, we can say we're in the same boat, and that was at my practice as well. We can explain the situation. It's a national problem, there's a problem with recruitment, we can say everything is being done to help resolve it, and so on. What specifically can we advise them to do in the very short term? You've mentioned ringing 111, which is a challenge in itself to get through to anyone. There's no point ringing the practices, local practices, because they're not going to be able to manage if they might do some other areas that don't face quite the same problems. So apart from calling 111, is there anything else? I mean, somebody said that there is it's not ideal, but there is a walk-in clinic in Newcastle or something. No. So yeah, I mean, so the first question is, what specifically should we say about the here and now and people in critical situations? And the second quick question regarding the long-term issue, there's an issue of recruitment and retention. What's the issue, again, somebody mentioned it and you also want to check that this is correct, that a while back a cap was put on how many people could study dentistry. Is there any cap or anything on the numbers? The
Higher Education Funding Council periodically look at the number of undergraduate positions that are required, and it's varied upwards, downwards of many generations for a variety of reasons. In the 1970s, with the advent of fluoride toothpaste, the indication was the amount of dental disease was significantly reduced, and so in the late 1970s, the number of dental schools was reduced in size. A reflection that needs have changed. So in the 1980s, there was a reflection that there was in fact now undercapacity of undergraduate training, and so the Funding Council increased the number of undergraduate places with the advent of novel universities, the University of Central Lancashire, the Peninsula University, and one more, Hull. And so new dental schools were created to increase capacity. Currently within England there are 920 graduates per year. The problem isn't numbers, the problem is the difference in attitude, I would say, that young people have towards work-life balance. You could argue, if you were being positive, that it's a very healthy attitude, that they have a much better attitudes towards work-life balance than I did. But you could also argue that they don't work long enough, hard enough, and often enough, depending on your perspective. But you certainly don't get as many whole-time equivalent years out of a current dentist as you do out of a dentist that graduated in the 1970s and 1980s.
Do you think there's anything that they can do in terms of the sort of funding, in terms of, if you qualify as a dentist, we'll pay your way through, we'll pay this amount, and as long as you work this amount, you never have to pay anything back. Do you think there's anything that can be done, incentivising like that?
Tie-ins are being currently discussed. As an example, foundation training, which is very attractive for new graduates, and is compulsory if you wish to enter onto the performers list, costs NHS England about £150,000 per placement per year, and yet there is no tie-in, and so they can complete their foundation training year, and then the day after they could exit the health service. And so amortisation of training costs is currently one of the things that's being looked at on the national front sorry, don't use those words, on the national agenda to try and tie practitioners in to amortise their training costs into the health service.
On this, what's the specific advice to give people in critical?
So in terms of the short term, if a patient has got an urgent dental care need, I think it is still worth them contacting practices to allow that triage to happen. As I say, we commission a number of units of dental activity per year. I think we are encouraging practices to keep urgent access slots, so the position can be variable. I know that's very frustrating of ringing around practices, but it's certainly still, if you've got an urgent dental care need during the day, it's certainly worth still doing that. I think it's important that they do tell the practice up front what their problem is. If the practice aren't able to help them, then I think asking to be put on their short notice cancellation list would be another option. NHS 111 can be accessed both via the telephone, but also via NHS 111 online. Again, that will be a clinical triage. We are trying to increase the amount of access slots. Our number one priority is to get more urgent access slots into the more challenged areas. So whatever capacity we're able to commission, they will be our number one priority. I think there is a difference between what you and I perceive as being urgent and what can be deemed as clinically urgent. So the triage will really prioritise those in the greatest need. So, for example, if you've got a broken tooth, that might be a problem for you, but if you're not in pain, etc., then, you might not necessarily meet the clinically confirmed urgent dental care need. I think if you are given self-care advice and your problem escalates and it does get worse, then absolutely ring 111 back or ring the dental practice back and tell them that the position has changed. So I think that's the current advice that we can give at the moment.
Thank you. Sorry. Councillor Hunter and then Derry Newton.
Right, thank you for that. Yes, it's been very informative. Hopefully we can try and get a press release out, working between Healthwatch, NCC and yourselves, just to try and keep the people up to date, because the residents on the ground don't think anything's happening. We can see that you're doing a lot of work to try and resolve the problem, but it's trying to get that message out, and I appreciate there's only so much you can put out, but I think even if we can keep drip feeding so that what's going on, how long would you estimate procurement take? I know it's like probably sticking your finger in the air. And also on the changing the UDIs and putting additional in, would that mean additional cost to the member of public, even if they're getting NHS treatment? Because I know that bans are worked in treatment. They're my first couple of questions.
Okay, so in terms of a procurement can take anywhere from sort of 9 to 12 months. I think the key is to make sure we make the contract attractive enough. You've got to get it out there. You've got to give them time to respond. Obviously, any new provider would need to secure premises, so you've got to give them sufficient time to be able to do all that preparatory work. So it's not necessarily a quick fix. We are looking at probably upwards of 12 months, and that's assuming that we get a successful outcome to that procurement. In terms of the additional units of dental activity that Simon referred to, the bans have stayed the same for the purposes of patient charges. So there is absolutely, in any of these reforms, there is no change to what are the national dental charges. Patients will continue, those patients that aren't exempt, and some people are, so children are exempt, and obviously some people on certain benefits are exempt. So the charges will be the same as it's laid down nationally. There'll be absolutely no change in that.
Another question I had was, is there any chance that we can provide maybe a service into the schools, like used to be done years ago, even if it's just sort of that dental check over, and it's to try and, more the cleaning and that, and then educating youngsters and families as to what's the right way to clean your teeth, because yes, it sounds a simple process, but if you don't clean them correctly, you can be spending 10 minutes a day cleaning your teeth and not doing it of any benefit. And I think it's going to help the dentists in the long run, because if we can catch it early, catch that.
So in 2013, the responsibility around oral health promotion transferred to the local authority. So the contracts that we had and the funding that we had obviously went over to the local authority. And I don't know whether you want to say some more about.
Yeah, and Jim, you might want to come in as well. We do have an oral health strategy for County of Northumberland, and that does include the likes of oral health promotion, where we try and hit key settings. So we work very closely with the likes of children's centres and also with our schools as well. So that is a full programme that we do look to deliver, and it is currently being reviewed to make sure it's as targeted as possible as well.
Thank you.
Derry, and then Councillor Dodd, and that will need to be the last speaker on this.
Okay, thank you. Pauline, thank you very much for that, which I thought was very comprehensive, and as I know from previous conversations we've had and with councillors with you, that there's been a lot of work behind this. I think for me, there were two good bits of information coming out, which I was very pleased to hear about all the work that you're doing, but I think certainly things like updating the NHS website so that it actually reflects availability is really important. It's something that we locally and nationally as Healthwatch have been calling for. So we're really pleased to see that, and also the suggestion that you're looking at wider providers than, so the Northumbria conversation. I think when we talked about that originally, I'm sort of really pleased those things to be taking up. I suppose, though, my concern comes back to what we spoke about when we met previously, which is, I think, as Councillor Hill said, as Healthwatch, our biggest concern is communication with patients and residents of Northumberland, but particularly in Berwick at this time. And I think it is that ability to react to a really hot situation that concerned me, because I don't think that getting the letter from the practice and then saying, well, talk to your local Healthwatch and then or talk to the CAB or your counsellor is good enough. It's not good enough communication, because what we've found, and as has been said earlier, is that we have no more information than people can get anyway, and that is not enough when people are really worried, and I think it's left us all feeling very frustrated. So I think better communication about your plans, and I think part of this afternoon is really important, because you're not here to reassure the council here, you're here to reassure the people of Northumberland and Berwick, I would say particularly, through this. But I think, what plans have you got about communicating with patients and populations, and is there something that NHS England or yourselves or the local network could do about supporting us in being able to signpost and advise people where to go for help? I think it just needs to feel a bit more that the patients aren't being left in limbo, but we're not being left in limbo with them. So if there's any sort of, what I would say to you is, please think about not just sending the letters out, putting something around that, like a task force is what I would suggest in these circumstances, but something that actually goes around people in those circumstances.
So I absolutely agree, communication is key. Just to reassure you, obviously we provided the initial information to go out to the patient letter when the Berwick practice closed. We've also been producing on a regular basis stakeholder briefings that have been circulated far and wide. I'm hoping that councillors have actually seen that and the committee have seen that. In that are some frequently asked questions. It provides information on what we have been doing, not necessarily bespoke to Northumberland, and I absolutely agree and happy to work with you on some bespoke communication for Northumberland. We have worked with Health Watchers on a myth buster to try and support, but I think I'm with you, Derry. I think the more we can communicate, the more we can provide the assurance that, we are working on things behind the scenes. I appreciate it's frustrating for patients, for your residents, that they can't see some of the work and the discussions that are happening. There are certain things that we can only see at the moment. We don't want to overpromise, I suppose, something that we can't deliver, but absolutely happy for to get together with our comms and maybe look at what we can do, particularly in the Berwick area, to get some more communication out. Happy to do that.
Thank you. Councillor Dodd.
I'll be brief because I know that you've got a timetable to keep to. This problem isn't new in this county. It's been all around. Is Berwick now at a disadvantage, or have they just been lined up with everybody else?
I think it's fair to say that access in the north of Northumberland is particularly challenging. So if I think about the patch that I cover, which is the whole of the North East and North Cumbria, I think the top part of Northumberland has got some of the access challenges that we've got in North Cumbria. Unfortunately, it seems when I speak to my commissioning colleagues in other regions, I think when you have workforce recruitment and retention issues, they do tend to be more prominent in the more rural parts of the patch and more challenging to address. So certainly Northumberland is on our radar as one of our top areas to try and address as a matter of urgency alongside North Cumbria.
Thank you. And because Councillor Dodd was so brief, Councillor Bowman, I think we can take your question. Pardon? It's going to be very quick to make up for it. Thank you.
Yeah, thank you, Chair. I'll be brief. About contract reforms, 8 years of despair. It's been on the books a long time, hasn't it? Do you see the contracts actually coming to fruition, whereby the situation will change, whereby the NHS dental care will not be privatised as it is by the back door, as we see at the moment? When a dentist is not satisfied with the service he's receiving from the NHS, he walks out and goes private. Can you see the reforms coming about within 12 months? Or can you see another 8 years of despair where the residents, not just of United Kingdom, but more importantly, the residents of Northumberland will suffer?
So there is a lot of work going on at a national level. There's a really wide engagement, and that includes with the profession themselves. They're going to be engaging with patients. We are certainly feeding in some of the regional challenges, and we're also putting forward potential solutions and areas to focus on. There is a sense of urgency in terms of trying to move to the next lot of reforms. We're not clear yet what those will be, but we know that there is a sense of urgency within NHS England because we are experiencing more contract handbacks, etc. So I think the impetus is there. I'm hopeful that we will see more measures. They can never come quick enough for anybody, but I think obviously we've got a vested interest to make sure that they do focus on the right areas and come as quickly as possible. Meanwhile, we are trying to do everything we can locally to try and improve the situation and be innovative around the contract flexibilities that are already in the system and how we use them.
Thank you very much, and thank you all three of you for coming. I know you've got to get to Durham, so we'll let you get off and we'll move on. But thank you very much. Chris reminded me that I missed off the agenda, the Health and Wellbeing Board minutes. So has the committee got any comments or issues for consideration from the Health and Wellbeing Board minutes of the 14th of July? No? Right. Now, the next item on the agenda is the Health and the Northumberland Inequalities. The members of the Health and Wellbeing Board, you have this on your agenda on Thursday. So if you'd like, I'm not throwing you out, you're welcome to stay, but you may not wish to sit through it twice. So I'll just, that. Thank you.
make.
Right. Yes, sorry, I'm busy sorting papers. No. So we have the report of the Interim Director of Public Health and Community Services. Jill O'Neill is going to present this, and it's the Northumberland Inequalities Plan. Thank you, Jill.
Thank you, Chair, and hopefully you've had time to read the detail of the report, and I believe there's hard copies of the slides that you've got in front of you as well. I am going to try and find the right button to begin with. No. There we go. Sorry about that. So, yeah, you've got the detail in front of you within the report, and what I would like to do is just try and tell you the journey that we've been on to develop the plan, and then share with you the proposal that we're particularly wanting to take forward over the next 2 to 3 years, as well as our long-term indicators. So the journey did start with a summit, which I'll briefly go into. We went back to Health and Wellbeing Board in the April, and the Health and Wellbeing Board asked us to set up a small task and finish group to advise and guide the development of the plan, with a key aim of developing a plan by September. So quite a rapid delivery timeline for us. But we didn't want to do that so much as in just a few of us get around the table. So we decided to develop locality events to broaden out the local conversations. So in brief, and hopefully some of you were there, we had a call to action from Councillor Glenn Sanderson to say that it was all time to get all of us in a room, or as many of us that could attend, because we were still under COVID conditions at the time, to consider how we were going to bring all of our plans together, but also to celebrate the strengths of Northumberland, because this wasn't about starting afresh. This was about really sharing understanding of what was already happening in our local communities and what was already being undertaken to address inequalities. But we also wanted to take a step away from individual behaviour change and really start to think about those broader, wider or social determinants that impact on our day-to-day lives for our residents, and also how we work within the county of Northumberland. So we were delighted that we had Cormac Russell attend, who is an international expert on asset-based community development, and also it was chaired by Professor Chris Bentley, who has worked for many decades under the National Support Team and the Health Inequalities programmes of work. And from the Inequalities Summit, what we were able to pull together was some key priority messages. And as I said, that was just the start of the conversation. But it was very much about how we improve our data and our insight sharing. So a key message was all about how we have different conversations with our wider stakeholders and also within our residents and our communities, taking a much more broader upscale approach to community-centred approaches, and how we really make sure we're aligning our organisations not only around funding but our resources, such as our workforce as well, and really absolutely pushing ourselves to look at everything through an inequalities lens. And the key concepts that keep coming out, and you'll see it throughout the plan, is the 3 questions that Cormac Russell posed to us, and that they are: what is it that communities do best? What do communities require help with? And what do communities need outside agencies to do for them? And we all play a role within that, and very much trying to galvanise that conversation around participation, not representation. And you'll see the banner and the branding below from Thriving Together, and that's because this isn't a council plan, this is absolutely a system plan, and we also very much want it to be cross-party plan as well, because this is about having a common shared purpose that we can all hopefully get behind. So, as I mentioned, we then embarked on 12 locality conversations. I do fully acknowledge we could have had 30 locality conversations, and we wouldn't have reached fully into all of the towns and villages and hamlets. We were under quite tight time constraints, but we did try and make sure we got out and had broader chats in the coastal areas, the rural communities, as well as our urban communities as well. Very much focusing around the 4 domains of inequality. So looking at not only protected characteristics, but the geographical impact, the socioeconomic, as well as inclusion groups. And we we wanted to bring together social and economic regeneration into the conversations. So we were delighted when our regeneration colleagues were part of those conversations, looking at how we bring people and place together. And we were able to use some tools, such as the Place Standard tool, where we were looking at our stakeholders, answering questions around what is it like to live here, what's it like around your sense of control or your public transport or your work and local economy. And we also had exceptional examples of good practice. And in the centre there is Aidan, who works in Cramlington. And we had some video inputs for people who were really living their lives and what was being led by communities. So, as I said, we had the 12 events. They were sponsored across partnerships, so not just the council, but very much Northumbria Healthcare Trust and the then CCG as well. And we had over 400 stakeholders signed up. This wasn't about conversations with residents yet, because we felt that we weren't mature enough to get to that point. This was about broadening out into our professional groups, whether that be town and parish councils, health sector, VCSE. Derry from Healthwatch was critical and participated in nearly all of the events, as well as volunteers, residents associations. So a real eclectic mix and diverse audience at every event. Some were large, such as Cramlington and Blythe. Some were really quite small, such as the Holt Whistle one. But the opportunity to participate was hopefully there. The analysis and feedback from the events was all about how we developed this plan to make sure the voice is reflected in the county-wide plan. So we spent July and August analysing all of that data that was generated, the maturity matrices to see how people thought we were mature or not in relation to community-centred approaches. And where we were asking people what were the top 3 things to include in a plan, we were able to develop those at a locality level as well as into a county-wide plan. And we've also post the events undertaken a survey, and albeit only 53 replied, we still got some really positive feedback, and where you could argue was less positive was only because people were saying we've been doing this for a long time, and it's more about delivering it to scale. So I think that was, in a way, a negative that you could turn into a positive, because it's about building on those strengths, which is what we're trying very much to do. So the next stage is that, obviously, we want to come here. We're at Health and Wellbeing Board, but we are developing locality newsletters. So every area will receive a bespoke outcome from the event, and then we've themed that into our county-wide plan. And there was many people who couldn't attend the event, so we are in the process of developing a webinar to be able to share that wider for any stakeholders who'd like to participate in some of that learning. So trying to bring it all together from a system perspective is really quite complicated, and we don't want to undermine individual organisations' autonomy in any of this. There's a huge amount of work that's being undertaken within the council, and the corporate plan's got a key pillar around inequalities, got Northumbria Healthcare Trust and its community promise, and so on underneath. And that's about how we bring all of those plans together. And we've done a recent refresh and review of the Health and Wellbeing Board across the county, and it's very much still fit for purpose live strategy that we want to reinvigorate and see how the Inequalities plan shines a spotlight on some core areas. But ultimately, if we deliver against the 10-year health and wellbeing strategy, we will be heading in the right direction around our inequalities. And we've got massive opportunities to work closer as we are doing so with the North of Tyne Combined Authority, certainly around the likes of inclusive growth and transport and things. So hopefully that's where you can see what we're trying to do is put communities first in all of this, and we don't need to reinvent the wheel, because Professor Sir Michael Marmot has done the evidence base, and we know what the indicators are that we're looking at, that if we work towards those over a long period of time, we will get there in relation to closing that gap that we aspire to. So if I was only allowed one slide, so I was fortunate enough that the chairs allowed me to have a few, but this is one slide that would hopefully try and summarise where we're heading, and that is about having 5 principles and 3 questions that we would like to thread through everything that we do going forward, from our strategies to our plans to our day-to-day business. And that is looking at everything through a true inequalities lens, not only protected characteristics or socioeconomic, but that rurality and geographical lens, as well as inclusion groups. It's listening to the voice of residents as well as using our data, and how we do that through resident surveys, but also having much more richer conversations out in our communities, building on the work that elected members, town and parish councils and such like do. The community strengths first, enhancing our services to ensure equity and access to opportunity, and that's very much how we look at making sure everyone has that same opportunity to access no matter what their background. And then what we're already doing, and certainly the Northumbria Healthcare Trust with their community promise, it's maximising our civic or statutory level responsibilities, so we can do the things such as looking at our local supply chains, our local workforce. All of that combined with asking those 3 questions set out by Cormac, and that will help us really empower and look at what is it that can be done by communities first, and then where can we help and where do we need to do more because it's our responsibility. I know there's a lot of information on the next 2 slides, so I'm not going to go through all of it. You'll be pleased to know. But what we've tried to do is summarise in this slide and the next one what the key points are for the plan. We're fully cognizant of all the challenges that we're faced with, and obviously the bold and underlined one is the current circumstance of our cost of living crisis and the risk of that widening inequalities. So we need to be very pragmatic and realistic of what we can do over the next 6-12 months and then going forward. The key statistics, it's all about closing the gap, and sometimes these inequalities can be masked if we only look at a Northumberland level in our statistics. We can sometimes look like we're on a par with some of our national indicators, but when we dive down into our communities, that's when the gaps arise, and that's where we see there is that diversity, and that's where we feel that we can make a local difference in trying to close those gaps. I've highlighted in detail the approach is a community-centred one, and the screening of the questions, and the actions are about working differently and a culture change and a leadership change over the coming 2-3 years around looking at our workforce, looking at how we commission and deliver services differently, looking at everything through that inequalities lens and scrutinising that and maximising our corporate statutory responsibilities. And ultimately, let's get behind the Health and Wellbeing Board strategy, because that's where the bigger issues like housing or employment and skills sit and fit, and alongside the North of Tyne Combined Authority framework as well. If we put our inputs as a collective into this, then we're always stronger together, and that's what we're trying to push forward, which is why this is going to Health and Wellbeing Board and also going up to full council as well. You can see that this is about a 10-year approach, but there are short, medium and longer term indicators within the plan. And as I say, many of the indicators are from Professor Michael Marmot's evidence and research, but we also want to make use of resident survey and the likes of ONS, where they want to know what would it be like to live your best life, what's this good, and what percentage of residents have a good sense of belonging, and that's really important to us alongside the harder indicators. So briefly, what we're aiming for as we go towards the Health and Wellbeing Board on Thursday is, can we develop a compact where we all sign up and all of our organisations work on inequalities as standalone as well as a collective together. And the recommendations that we're taking forward for you to consider as well this afternoon are there for you, which is ultimately about considering our process of developing the plan, what you feel about the proposed short, medium and long-term indicators, and ultimately that we'll only achieve this if we are all behind it and working collaboratively together. Thank you, Chair.
Thank you. And Jill, if you had only had that one slide, that to me actually says it all, so it's brilliant, thank you. Right, the recommendation we have is to consider and comment on the inequalities plan. So, Councillor Hill, and sorry.
Councillor Hill first, wasn't it?
Yeah, Councillor Hill, Councillor Bowman, but so Councillor Hill, Councillor Nisbet, Councillor Bowman.
Thank you. I mean, it's difficult to think of anything as a subject which isn't any more important, and it underpins everything we do, what our philosophy should be about, tackling range of inequalities. Just to be cynical though, and just to share some cynical thoughts that were going through my mind when you were speaking, when I was reading this report, there's always a danger in these things where it becomes a great talking shop and a tick box exercise. it's similar. I mean, obviously very different to something like a neighbourhood plan where it tries to do everything, when some of the best neighbourhood plans concentrate on 2 or 3 key policies for an area. And I just think, I mean, I don't think, for example, to be very cynical, but I don't think in 2032 people are going to say, we've got so much equality and it's all down to the Northumberland Inequalities plan from 2022 to 2032. That was the difference. I would be tempted, given the cost of living crisis, to be very, very focused in on that. To be, you know, normally a council keeps a lot of reserves, but it would be justified to use those reserves. The administration can't do, which all administrations do. I'm not making a point against the current administration, so save up money to spend towards an election. That just cannot happen with the cost of living crisis. So I would actually like a much more focused in this crisis. And it is, I mean, it is so bad. I don't think we could overstate how bad it is. I mean, it's quite unbelievable, the stories you're hearing, and often we're not hearing when people's pride and things, how much people are suffering. It's just incredible. I never thought I would see in this country the widespread poverty that there exists now. So I just wonder what your response to that was.
Yeah, I couldn't agree more. And actually, it is good timing. It's almost like you planned the agenda, because the next item is talking about our public health underspend, and that links to within the Inequalities plan that we are developing a poverty and hardship action plan, and that is about really dealing with the now and how we can best support and work as a collective what's already happening, as well as what we need to do, as you rightly say, just within the next 6 to 12 months. And there is a bolded statement within the report I've written acknowledging that at the minute this is about trying to hang on to where we are, and not let the inequalities widen before we aim to level off and reduce. So I think you're right, we need to go into this with our eyes open and look at where we're at, and thinking about neighbourhoods as well. This is all about hyper-local conversations as well, and trying to start where communities are at, but it has to link with, as we know, local jobs and local supply chains. But yeah, it'll be good if hopefully by the time you've heard Jim speak, if that reassures you some way around how we want to try and address some of the now. But the poverty and hardship plan is still being developed, but it's imminent to be produced.
Given a sort of overview of everything, but that doesn't say there would be a big concentration and time spent on that.
Yeah.
Part. Yeah, great. Thank you.
Councillor Nisbet.
Hang on. I welcome this report because I did attend one of those sessions and I found it very welcoming. I really did. And if this goes further, I welcome it even more, because there's and as Jodie just said about the poverty and everything out there, and we've got a lot more to come. I just hope that people do listen, take this on board, and let them move on with it. And I'm pleased it's come here to go to the Health and Wellbeing Board, so it means we are moving somewhere for the future of it. So I do welcome it. Thank you.
Thank you. Councillor Bowman.
Thank you, Chair. Wow, what a fantastic report. A lot of aspects in it. When I read it, I was excited. If it comes to being the council's policy, it will be an amazing thing to see it rolled out throughout the county. I'm looking at my ward, and I know the deprivation that there is in my ward. My ward is like split. There's areas of wealth and there's areas of deprivation. And there's an area of, I would say, comfortable. But there is a problem, isn't there? It's all a mix. It's not one pattern, is it? It's many patterns. But I am aware that community groups, as it were, are not coordinated together. They're not linking up to each other. They're not working for the benefit of all the community. They might be working just for one aspect to serve the needs for one particular group of people. But when I read this, I can see this is going to be a complete game changer. I noticed on the first page, tackling inequalities with our communities, supporting our residents to be healthier and happier. those are two keys in it. We wish, as our friends leave, we wish them well, and we wish them to you know, when they're sick, we send them cards and say, get well soon and all that. They are the keys, but unfortunately, there's poverty running through the communities, and this poverty is ripping families and it's ripping individuals apart. I've got residents committing suicide. I've got all sorts of abuse going on, whether it's home or wherever. So I'm looking at a mixed picture. And so what do I want? What do I want at the end of the day? I want my residents to be healthier and happier. I want them to have a good life so that at the end of their days, in their retirement, they can think back of their life living in Northumberland as being a one of that's been really good, and it's been not just good for them individually but for their families. That's what I want. So will this bring about that? Possibly. Will it change the attitude in the community? Possibly. Will it improve the lives of individual residents? Possibly. The only thing that stops it is money, is finance, is opportunity. And if we can nail that one in the bed, then we've got it. But I can't see that happening at the moment. I'm sorry about that, but I do welcome it, and it's really good. Thank you.
I think it's fair to say that obviously we would always support additional funding, but I think this is about how we put inequalities into everything that we do, and so it's not about a standalone budget, it's about how the whole council, the whole trust, the whole ICB, and we know from an ICB perspective they're absolutely championing inequalities. It feels like we've got a real opportunity in a moment where inequalities is being talked about everywhere, so we need to continue to push and drive for that, but fully acknowledge this isn't a silver bullet, this isn't a single plan that's going to save the world, but it's hopefully the right culture and right approach, and if we keep moving forward with it and we see that over a period of time, then we can start to address some of those stubborn, wicked issues. So I think it's about taking it a step at a time in that respect, and trying to push that workforce change, that organisational change, and see what comes from communities and by communities as well, and have that different relationship. So, but thank you.
Any other? Councillor Hunter.
Yes, I welcome the report, and I think it's the inequalities and giving everybody the opportunity, looking at what gaps there is in every area, because there's some maybe in the west or in the southeast is different to the north. So it's giving everybody that opportunity, but I support Councillor Hill at the fact is we've got to look at this crisis at the minute, because it is a national crisis, and it's not maybe just always the ones that's been in poverty, it's the ones that unfortunately are going into poverty now because of the situation, and maybe are frightened to put their hands up and admit that they're failing to themselves and their family when they're not really.
Any other questions? Councillor Dunn.
Yeah, we're not unique in this country of having a problem or a cost of living stroke. Fuel is driving this, and we all know what one of the real problems is and where it is. It's a global thing. We've had a global pandemic, and now we've got this global fuel shortage, not shortage, but cost of it all. We will get through it somewhere along the line, but you know, I think the previous agenda, when one of the speakers said that children or youth of today are not prepared to do the hard work that other generations have done, that may have a bearing on some of this in the future. You know, because you said that they won't go to this, you know. So I think, you know, the perfect storm is on the way, that we've got a big cost of living crisis, and people are going to struggle. Just ask anybody that uses fuel in a tractor or a wagon and like that, and it's sort of, how am I going to get this paid? Or how can I survive? So it's right that we look at everything, but it's also right that we try to get through the here and now. And what that means, I do not know. But borrowing tons and tons of money has been proved that it doesn't fix the problem. Thank you.
Thank you, Councillor Dodd. I think that's probably, I mean, I would say it's not about money, it's about changing attitudes and changing the way we do it and using the money we do have for where it's needed. Thank you. That was really explicit, and I think I'm going along with Councillor Bowman to say actually that was wonderful. Can't remember your words, Councillor Bowman, but you were spot on. Thank you. So I'm just going to move on the agenda. And the next meeting, the next item is the proposals for the allocation of the Public Health Ring-Fence Grant Reserve, which you're going to use to reduce health inequalities, which is very nice. Means we move on to this a little quicker than we might have done. Yeah,
Chair, before we move on, I've noticed in part of it about the selective licence, and I should have declared the interest at the beginning because it is part of my ward, just in case I have to. Okay, thank you.
Great, thank you, Chair. So yeah, I'm hoping that this is a kind of natural thread through from the previous item. This is a report that's going to Cabinet next week, so really welcome your input, your comments on this report and your views on it. It describes I'm going to be fairly short, to be honest, because I'm hoping that it's fairly self-explanatory if you've had a chance to read the report and provide more time for questions. But so I'll really just summarise, I think, some of those key points. So the report describes, just for in case anyone doesn't know me, I'm Jim Brown, a consultant in public health, working in the public health team.
I just realised that just before you said it, I thought I didn't.
No problem. I think I recognise everyone. So whether you recognise me from my COVID pop-ups, I don't know. But that's probably where you'll know us. But thanks. And I kind of led the process, together with others within the public health team. So essentially, the report describes, as you can see, the process that we undertook to really decide how and make proposals to Cabinet about how we can make some additional investment into public health interventions using our accumulated public health reserve. And so really what we're asking Cabinet is to approve that allocation, but also to delegate to the Director of Public Health how we would use that funding, £1 million that we would set aside to address issues around poverty. The key thing I think that's really, really important is that there are conditions about how we use this money. It can't go to anything and everything. So there's a requirement that's kind of laid out in statute about that we have to comply with the conditions. The use of the public health grant has to be for public health functions. So what we have, and if we accumulate reserve year to year, that also has to be used, in accordance with the rules. So it does kind of limit. It cannot go on to everything. So really, what we have done here is pull together a kind of multi-criteria decision. Now it's a prioritisation exercise where we have agreed a number of criteria, weighted those criteria, and then asked our team and other teams that are across the council, others within the Executive Directorate in terms of housing, community services, adult services, children's services, to complete a template which was then submitted and scored and evaluated to really to help inform decisions about how this public health reserve might be used. I suppose you may be wondering, why have we got a reserve? How on earth have we managed to do this? Well, I think we've been pretty cautious, over the years. And that really is because we've had a lot of year-to-year of uncertainty about what our budget in public health would be. And it's really only often in the last few weeks before the beginning of the tax year when we've known exactly what our budget is. So we've had to be really, really cautious about how we've used that. But actually, we have a 3-year budget, and therefore we're really in a much better position to be able to make use of some of that public health reserve so that we don't have a kind of messy decommissioning of services that would arise if we had that kind of sudden loss of funding. So we really want to be kind of ahead of the curve in that respect. So in terms of the kind of results of this bit of work, there were 13 bids that we provisionally approved, subject to Cabinet approval. 4 of them are really quite small amounts and were actually approved really as kind of business as usual. And that left 9 of the kind of slightly higher cost bids, proposals, for public health interventions that we are proposing that we take forward. And that accumulates, so for the total would be just over £2.5 million. So really what I was going to suggest, very quickly, I can go through some of the principles around how for some of those higher costs, but both the criteria, the scores for some of those, and that list is included in that report that you have. So first of all, children's and young people's emotional and mental health support, 210,000, and I think it come, much as we've seen, some of the issues we talked about poverty today, we know that what we've seen is a massive increase in demand for support for emotional and mental health problems among young people. And really what we want to do with this funding is to strengthen that kind of prevention offer and develop resilience. Also really to provide that kind of additional time-limited capacity, to manage some of that increased demand. So really, as we're going to say with the kind of poverty action plan, we want a little bit of flexibility to work with partners to agree exactly how best that funding needs to be used. So there is examples of some kind of specific programs like Kids Incredible Year, enhance that existing BCS provision around counselling, some of those group approaches, to increase resilience amongst children in schools. But, just to really give an example, we've seen a doubling in the referrals to school nurses, and a lot of that has been for emotional and mental health problems amongst our children in Northumberland. Another is an evaluation of integration of services for children, young people and families. So this will enable us to really to work with an academic partner to evaluate the integration of services in Northumberland, including the new family hubs. I think many of you will be aware that we're embarking on a 2-3-year programme of integration for children and young people. Jill is involved particularly in that piece of work. And it's really important that we understand how that's working. We're able to kind of identify and share that learning about the process. Next is around Nhs Health Checks, which is a piece of work that I'll be leading. Many of you will know about Nhs Health Checks. They're currently within general practice for people without existing problems, aged 40 to 74, to reduce the risk of heart attack, stroke, identify those risks, help address some of those risks. What we've seen over recent years is that not only during the pandemic we've seen numbers of health checks absolutely plummet and actually a really slow restart, but what we've had even pre-COVID, and this fits with inequalities, we were increasing inequalities with the model that we had. So what we're proposing we use this funding for is to supplement the model within general practice with health trainers going out as a community outreach approach, doing point-of-care testing, finger prick testing, out where people live rather than waiting for them to come into general practice, where we know that a lot of people who have far more pressing issues, they're not going to race into the general practice. So whilst we agreed at our SMT to move towards a proposal where we'll use this funding to supplement our existing and some new health trainers to be able to do this community outreach and help reduce those inequalities, but also make up for this lost 2 years that we've had, of people who haven't benefited from the programme. And of course, we've already touched on poverty. And now that, as Jill has said, there is a poverty action group that is currently developing a poverty action plan. I think it's still in draft. And really what we want to be able to do is contribute, £1 million to that, because as you've said, we've seen massive inflation. We are in a crisis that will be similar, if not greater, in proportion to the pandemic. And whilst we would have wanted to come with precise details, what is really important is that we're engaging with partners right across the system, the BCS, within the council, within our NHS colleagues, so that we can identify where those gaps are and really understand actually what are we going to get nationally. We can wait and see what's going to be announced on Thursday by a new government, and that we can use some of that funding to look at those areas that are not currently, where there isn't currently funding. Those kind of examples, as we know, it's very difficult for people to obtain any funding for a new boiler if their boiler suddenly packs up and they have, they're going to go into debt if they need to, or they're going to be cold and not have hot water. But actually what's also really important in terms of those principles is that we need, in line with those conditions of use of the public health grant, to be really using it on sort of more upstream preventive approaches, and that's going to be a really important principle. So we're really asking is for delegation. We're going to be of decision making to the Director of Public Health, and we're really going to be intimately involved in the development of that poverty action plan. And the final one that I'm just going to talk about is selective licensing of rental properties. So this is actually a really effective tool to help improve the quality of housing, but also actually has a secondary method of kind of addressing some of the antisocial behaviour issues. But there is funding needed to kind of manage the process. Although it ostensibly can generate some income, it actually doesn't cover some of those costs. We know that housing has a massive impact on people's health. So that's going to be initially trialled in Coop and Key and is over a 5-year programme. So there will be evaluation inbuilt into that. So whilst we will get to the end of that 5 years, there isn't ongoing funding. There's evaluation inbuilt, so that can inform what our approaches are going to be going forward. And I think 5 years, to be fair, is quite a long time that for any kind of programme. There's a list of those other areas, and really happy to take questions from the chair as needed.
Thank you very much. Questions, comments? I'll just say before we do take them, this is a cabinet report, so the things that we say today will be taken forward as a report to the cabinet when they're making their decision. Councillor Bowman.
Thank you for the report. It's a vital report. I know that it's quite complex in its entirety as well. I am aware that it has reverberations within my ward as well. I'm aware that it affects the whole of the county. Just a few issues that I want to highlight in the report. Are you on about the NHS checks for transformation, trying to mitigate on heart attacks, strokes, and so on, dementia, and other items, I would imagine. Would communications help with that? If we did a lot more communications, it would be not so cost-worthy, but would have a benefit as well. The other thing is we're moving on to the poverty aspect of it. £1 million, that's equivalent to what, 4 houses in my ward putting up for sale. It's not a lot of money, is it, to mitigate on poverty? Poverty is driving people to take actions that I know of people who are starving, missing a meal to feed their children and so on. I know people who are decided to leave their heating off as opposed to get a big gas bill at the end of the quarter or the month or whatever, and sit freezing, as it were. I can see that coming, and there's 2 parts. One would be in October and another part in January when the costs go through the roof. I know a councillor pointed out that it is due to global aspects, as it were. But on a local level, what can we do to mitigate on that? Not a lot, really. The government ceased funding replacement of gas boilers. We're moving over to a green agenda, and hydrogen boilers will be coming in soon when we replace our natural gas with hydrogen. Don't know how many years that'll be off, but that'll be coming in. So I do have a few questions about the poverty. Selective licensing, yeah, I totally agree with that. I've got a certain patch in my ward, 92 properties. I'm not going to mention the place, but I've been asking for selective licensing for that part of my ward, and the answer keeps coming back no, because of the cost. And yet, you know, I've been to funerals of people who live there because of their circumstances. So anyway, just a few points that I must highlight. I do appreciate the report. It is in the right direction. It's come at the right time, but obviously...
Every time.
Yeah, but no, the question is, and I'm getting to it, do you need more money? Do you need more money to carry out this report?
Sorry. Thanks for those comments. Would you like me to respond, Chair? Yeah.
This item on the agenda is how you spend an amount of money you've been given. So I suppose the question is, what more would you do with a different amount of money? Not, do you need more money? Because we will always need more money. Yeah? But I'll let you answer, Jim.
Thank you. Well, why don't I just take each of those in turn, because I know I've had to make a note because I know that I'll forget. Otherwise, I'm just back from holiday. Nhs Health Checks, what you talk about communications and engagement. I think absolutely we did a survey of GPs and they were crying out for that as well, and that will be part of of what we do when we get this plan up and running. I think the only thing I would say is communications alone is rarely a successful tool to address inequalities, because the reasons why people don't come for a health check are generally because they've got far more important things in their lives, from their point of view, like paying for the food and paying the monthly bills, paying the meter. That's often one of the reasons. So communications alone, I don't think is enough. And actually what we're trying to do is not only get uptake up, but actually reduce inequalities in the uptake. So I think it's a combination. I'll give an example. In North Tyneside, they had a massive communications. I don't know whether I can remember going down the coast road and seeing big posters. It had not actually a jot of difference on uptake as what the Director of Public Health from North Tyneside did share. So I think you're absolutely right that we do need to think about communications and engagement, but I think we need to be really careful about how we do that and do that in a really careful way. All I can do is really about poverty in terms of 1 million. Yes, it's not going to cut the mustard, is it? But what we're saying is this is a contribution from the Public Health Reserve. Public Health grant is, help me out, 16, 17 million a year. It's not, compared to the NHS of about 450 million, I think, for Northumberland, and obviously total council budget, and obviously budgets in terms of how we could access benefits. It's nowhere near, and there would never be enough. But it is hopefully it's a contribution, and I hope it helps to kind of acknowledge actually the importance we give to this. That this is the highest amount that we that we would be giving. But I think you could you are only going to be mitigating. You're absolutely right. Selective licensing, I can feed back to our housing colleagues, what you've said, if you'd like us to do that. Obviously, to the to Liz Morgan, who is Executive Director, and to Phil Soderquist and Susan Turner, we can share some of your interest in selective licensing. I think what you're saying about more funding. I think what we're doing is I suppose sharing the process that we've used, which we're hoping is relatively rational, transparent, accountable about the money that we have available to us, and how we've used a process. We used it actually for the public health budget several years ago as well, and we'll be using that process again, and hopefully sharing that with NHS and other colleagues. That it's just a relatively kind of not objective, but semi-democratic, accountable kind of process that we use, for using the money that we have currently available.
Thank you. Just a brief comment, really. From the Healthwatch perspective, we would particularly welcome the proposal regarding young people and mental health. It reflects everything we've heard, certainly over the last 5 years, and I think we've done a report every year around the need for support with resilience with young people. And I think it just goes to prove that change does come. And so we would be very happy that we have contributed to where we've got to in your proposal. So, yes, that's welcomed from Healthwatch.
Thank you. Councillor Hill.
Just a quick question. I mean, obviously, I broadly support this, like I think is the view of the room to go to Cabinet. Just on page 53, regarding use of the reserve, 100,000 to part fund a strategic creative health manager shared with CCG. So essentially, NHS is spending 200,000 on a 3-year post. I know a lot of people would think, talking about poverty, how much you could do with £200,000. I think about how much families you could help. I know there's limits to what you could do with funding, but just to say, if there was a funding of £200,000, if we had that in Berwick, that with conditions to go directly to families that can't feed themselves, that can't heat the houses and stuff, you could do a hell of a lot with that money. Is another health manager the best use of £200,000?
Thanks, Councillor Hill. Chair, is that all right if I just respond? This actual paper isn't seeking the approval of that because that's been previously agreed. I think, I suppose I'd answer that in two ways. One, I suppose I have a lot of sympathy for that approach, and I think there are arguments about how you use money and whether you just give the money. And we've had a lot of those discussions within our own team, and obviously trying to manage that in terms of the conditions of the public health grant and how we do that. The one thing I would say though about the creative health manager, I can utterly understand why there might be cynicism about that. You may well know about BATE, which is in our Arts for Health programme in South East, Northumberland. And if you talk to some of those people about some of the work that's been done, that has built, increased their confidence and brought them much closer to work and to the employment market. And it's really increased their employability, through using lots of, so accessing their strengths and increasing their confidence. So I think there's abundant evidence actually in terms of how the arts can really improve health, and as long as it's done in a way that focuses on people who are most likely to benefit and who wouldn't otherwise access some of these arts for health approaches, but actually the evidence in terms of its improvements in well-being, in employment, in terms of general health is actually really quite overwhelming. I can share, there was an all-party committee report, wasn't there, on arts for health that was published through the summer, but in fact Liz Morgan's Director of Public Health report on arts for health and creative health as well just really outlines that evidence. So I can absolutely understand where you're coming from. Yeah, I mean, there's a report gone to Health and Wellbeing Board, which I'll share with you just, it was about 3 months ago, I think, and I'll share that with you so that you can really just kind of outline what the rationale was. I think it is useful
to have that evidence, because now people are saying, when they see sort of salaries and things like that, they are saying how many people without feed and so on. But if you said this has directly led to approximately 50 people, increased chances, and then if you calculated that, it seems cheaper. If that is the case, if the evidence is there, cheaper the price because of the benefits. So it is. I think we need to show that evidence moving forward to back those up, because I think people automatically do ask those questions more, don't they? When
it's quite reasonable.
Yeah.
Thank you. And we did have the public health. Did you mention that public health report from a few years ago was very clear about the benefits of creative health? Yes. Councillor Hunter.
Yes, I welcome the 210,000 for the emotional and health support for young children, because they are still suffering from COVID. Because as you speak to some of the schools and until that's sorted, it's affecting their education. So it is that knock-on effect. So I think it's a case of, you know, it's 210,000, but as long as we can use it wisely so that we can help youngsters come forward with their education afterwards.
Thank you. Any more comments? Councillor Nisbet.
Yeah, I just welcome this report as well, especially the young people's report. I think that's brilliant. But also on the selective licence, and as I think many is aware that this has been an ongoing situation for quite a number of years now, with absent landlords and stuff like that. And it's just, I really appreciate this, and I hope it does happen. I know it's going to bring a big downfall in the area, but it'll also rise back up again and be more effective, and people want to live there. So I do welcome that report on the whole. Thank you.
Thank you. Just kind of, I suppose, footnote is that the selective licensing will, does need to go out to full consultation. So, I suppose this is not the end of the process either. Yeah.
It is a pilot, that though, isn't it?
Yes.
Trial it. Councillor Bowman mentioned that he'd like to put it forward in his ward. So if the pilot's successful, presumably that will move forward. Yeah.
Dependent on funding.
In that case, we'll move on the agenda. Thank you, both of you, for coming. You're very welcome to stay, or you're very welcome to get on if you need to. Yeah. We've just got, I think, the last main item on the agenda is the Healthwatch. What's my agenda? The Healthwatch, Northumberland Healthwatch annual report for 21-22, and Gary's going to take us through it. Thank you.
Thank you very much, Chair. Thank you and good afternoon. And as ever, I'm delighted to present the report of Healthwatch Northumberland. This is our annual report and covers our statutory activities. As everyone in the Chamber will be aware, we are a statutory activity that you as a council commission. And at this point, I'd also like to thank the council for their continued support in that commission that has allowed us to do our work so consistently over the last years and into the future. I think the picture on the front is very pertinent with where we all are at the moment, where we are all, although we are always focused on Northumberland and directed towards Northumberland, we are also very aware of our borders now. And a lot of what I'm going to say in a moment will talk about the fact that, the word integration is the new hot word, isn't it? So we will be doing a lot of that and a cross-border work. But what I want to talk about this afternoon on my next slide, sorry, I keep thinking someone else is going to do it for me, is talking about what championing means, because that's the title of our report, championing what's important to you. And the you in this context is the people of Northumberland. So championing, I would say the most obvious examples of that and what we do is the active listening that we do. That is the first thing that we do. That is why we're here. That's what Healthwatch is all about. We actively listen to the patients, the residents of Northumberland, people who, the service users of Northumberland, whatever you want to call them. I prefer to call them people. The people of Northumberland who are using services within the county. And that active listening means that we listen, we hear, and to all the means you've seen in our report, that people come to us, but that we check back. We say, well, what does that mean? We check back, we analyse what we've heard. So we check back with people when they've told us stuff. What does that mean? Tell us a bit more about that. Let's talk to the services involved. Let's understand a bit more. And when we've done that, we then convey what we've heard. We report it. We talk to the services concerned. We feed it back. So they're the most obvious examples of what championing means. That's how we're described in legislation. We are a champion. But I think on that slide, what I've tried to do there is try to pull out some of maybe the more less explicit means of championing and encouraging and working with services to involve the public. And I think that's been one of the things, and I think most of you have sat in meetings with me where you know that the first time I put my hand up, I'm going to say, well, what about, have you spoken to the public? What did the people think about this? And that's why we were so pleased to be involved in some of the pieces of work we've been with Public Health this year and the Council and with the health service. Because I think what we've been able to do sometimes is help people step back, services step back and see the bigger picture. And I think that's really important. And that is, for me, what we are here to champion. I think in doing that, what we're trying to do is we are creating empathy, so that shared understanding of problems and issues. And I think listening to some of the conversations this afternoon, this point has become very real to me, is that by creating that empathy and by bringing experience into debates, so what has actually happened to someone who has not been able to get a dental appointment, or has felt that they've not been able to get the service they need when they want it. What does that mean? And I think what we've been able to do is bring that along to enrich the data that you all get. And I was really pleased to see within the Equalities strategy that whole thing about it's not data alone, it's data plus experience. Because without the experience, the data only gives you the what, the experience gives you the why. And if you don't have both of those things, then actually you can't address and find a solution. So I think that is really, really important part of what we do in championing what we do. We're also, obviously, because that is basically, again, in legislation, what we're here to do is to improve care over time. And I think that, again, as I said in my previous comment on the last item, improving care takes time. And none of us are, not aware of why that happens. And I suppose the thing that we at Healthwatch Northumberland are always very aware of is that it's a partnership, that it is really, really important that we all understand the parts we have to play in our different roles. One of the things that one of my other little things that people have heard me say a lot is that we are not a decision maker. You're the decision makers. All we can do is seek to influence you and give you that empathy, give you that understanding of what is happening. But the choice to act or not to act on anything we say or recommendations we make is yours and yours alone. And I don't think we've got any health colleagues in the room, and yours as well. So we're very much aware that it is a partnership, and what we can do is encourage you to make those changes. The thing that we can own, and what we will say, is that we will have told you, and you then can't say you haven't been told. So I would say that was one of our key missions that we do, and hopefully you'll see that through the report, not just this year, but in all years. So what did we say we were going to do this year? Those of you who were at our AGM last year online, very happy that hopefully that's the last one online. These are the things that we said we would be doing. These were the things that Northumberland was saying was important to them, and I think it's really interesting that we're still talking about those things. So 12 months on, which probably says, these aren't problems that are going to go away at all. So they're the things that we said we would do. So we said this would happen, and indeed it did. So just looking at some of the, again, going back to what I said about the outcomes of what we did, so what happened as a result of all the activity that is detailed in our report happened. The End of Life project was one I think we were all particularly pleased to be involved with at Healthwatch. It was a joint piece of work with the CCG and with the NHS. And we are now awaiting the final publication of that in the council, and we're now awaiting the publication of that strategy. Hopefully, that I understand that will be in the autumn, so I'm quite pleased to hear that, because again, I think it was a really good piece of work where I think there was a formation of ideas, but actually when we went out to the public and we engaged with public, very different things came back. And I think that was what was important about it. I think that really did help shape and change the direction of some of that strategy. Well, dentistry got a whole lot hotter. Last year it was there. it was sort of starting to come up, the list of things that we were hearing about, with GP access, but all of a sudden, dentist access started to come up. Slightly overshadowed slightly by the COVID vaccinations, but dentistry just powered on through, and this afternoon we have absolutely heard why that is going to continue to be an issue for us. I'm glad we've got Neil in the room this afternoon, because obviously the other piece of work we did was the home care project, which was followed on from a piece of work we did a couple of years ago, which was talking to people about the care they receive at home. And I think it was a really interesting piece of work. I think it was quite hard to hear and listen to, and I can understand that. And I think, you know, it was really good to have that conversation with adult social care partners to actually understand the context and the pressures. And I think if you read what service users were saying, I think there was some understanding there as well. So I think it was both a challenge and an acceptance from service users, but a really interesting piece of work which we're hoping to develop further. Primary care, I'm really pleased with the work we did around the patient participation groups, and really looking forward to taking that forward as patient participation groups get going again, because they were one of the big things that missed out, that public voice, that patient voice in primary care during the pandemic. PPG stopped for a long while, and it was important that we now push on with those. The ICS, yes, this is where the cross-border stuff. Our focus will always be Northumberland, absolutely in focus, but we are working much more closely now with our network of North East Healthwatches, and we now have a network and a protocol about how we will all work together, so that information from across the North East and North Cumbria patch Healthwatches will be fed up. We've got a structure for how that will work, from the place level to ICP level up to ICB level. So that flow of information will happen from across the piece, and we will play our part. So Northumberland will definitely get heard. We're not going to let that go, but it's going to be bulked up with everybody else's, and I think that's really important. Healthwatch has also got a representative who sits on the ICB, and it just so happens that the Healthwatch network chose the Healthwatch Northumberland chair, David Thompson, to take that place for the first year, and we're very pleased about that, because David has done a lot of work to championing the importance of the public voice in the ICS development, so that's really good. Health inequalities, well, yes, we have refocused our work entirely on that, and that is, you know, we're going to do a different annual survey this year, very different. We're not going to do the big mass survey, because I think, you know, that everyone's surveying everybody at the moment, aren't they? Everyone, you know, everyone's putting a survey in the field and just going, no, we don't want to do another one. So what we're doing is we're going to do smaller, more focused group work, and we're going to hear from specific communities much more closely, and we're working on that. So if you think that in your community there is a particular group who you would like to hear from, you know, talk to us and tell us their issues around health and social care, we're happy to set that up, and we'll be doing that towards the back end of the year. So, for example, one of the communities we're particularly pleased to have engaged with is the fishing community. So we're working with the mission to seafarers and listening to the issues that people in that community have in terms of health and social care services, which I think is really, really important. It's about, you know, those other voices. The advice and information, or signposting information, is one of our statutory activities that perhaps doesn't always get doesn't always come up when you think about what Healthwatch does, because actually it's not, although it's absolutely our statutory activity, it's not always a thing that people think about for Healthwatch. But again, I think it's what comes out of it when you look at the issues that people are coming to us about. Very often the biggest theme is communication, and that if services communicated differently or a bit better or sooner, then actually some of those, and what we've been able to do sometimes, and I think if you look at the examples in the report, sometimes if we've been able to get that communication between service and patient going, then actually it heads off, it's preventative, it stops it escalating. So that's what we did. None of you is going to need to come to our AGM now because I'll have done all the talking. So, what are we going to do next? We are going to, in the next couple of months, we're going to produce 2 reports specifically. One about the experience of families who have children with autism but have also wanted to or needed to use mental health services. And this this is one of those issues which, once we started asking, we found it grew. So that's going to be a very interesting piece of work, and we're hoping, we are engaged with the development of the autism plan, so that will feed into that. And also a report that we're just finishing off, having worked with Vision Northumberland, which is about the general experiences of people with sight loss and what's called the sight loss pathway. So if someone first loses their sight, what is their experience? How does that work for them? And I think some of the COVID stuff will come out of that, but I think it's also more general. And again, it's that health inequalities. What are the barriers that people with sight loss are experiencing? So I'm very pleased to be able to do that piece of work. As I say, we are completely changing the way we do we're going to call it the annual conversation, not the annual survey. So I think that's a much better phrase. One of the pieces of work which is going to be a focus for, it's National Healthwatch England, but is obviously, because we as individual health watches are concerned as well, but is the impact of the cost of living pressures on health and health inequalities. And I think I was struck earlier about that conversation about dental charges and things like that, and how is that going to then impact on people's experiences of services. So I think, again, that is something which we will want to follow closely. We are already talking about and looking at different new ways of delivering social care, and also we're working at the moment with Northumbria at looking at how outpatient services are delivered. Now, if you've not already done it, go on our website, and there is a survey. I said I wasn't going to do surveys, and I am doing surveys. There's a survey on there which asks you about your experience of outpatients, but also some ideas about how the future might go. So it's worth having a look, and if you haven't, spread it across your networks. So the other things that I would say is that they're the sort of things that we're doing already. Some of the things we already know we've got in the pipeline. I think I've heard things this afternoon that I definitely want to get involved with. I think some of the issues around health checks, some of the making every contact count, I think all of those things, I think Healthwatch has a role to play in those. So I'm going to be really, I'm never going to be off Jim's emails probably at this stage. He's so happy. So what I would say is that finally you will hear a reprise of this at our AGM in October the 19th. We're going to be at the STEM Centre in Ashington College. And the theme of the AGM this year is all change. Because it is, isn't it? It's all change. So do come along. I am delighted that we have 2 excellent guest speakers this year. Neil Bradley, who's sitting at the back there, is going to play a starring role, and Rachel Mitchison, who's our place director, because they're leading everything. They're leading the change that we're talking about. And so hearing what they're going to say is, I think, really important for the people of Northumberland to really hear it from the horse's mouth. So do come along. If you've not already had your invite, it will be in your email inbox in the next few days. Come along, join us in Northumberland and Northumberland College, and we look forward to seeing you there. Happy to take any questions.
Thank you, Derek. So, questions, comments to Derek? Councillor Hill.
Thank you. This is a very nicely produced report, by the way, particularly page 13, which is of my ward. Not only my ward, but where I was born as well is captured in that photo. So, just a quick point. Actually, I did mention this last year in terms of the reaching out. 1,167 people shared experience of health and social care services. I probably get about that a year myself. Just people coming up in the street in the supermarkets with health is obviously a big issue. And what 3,000 came for clear advice and information. I mean, there's obviously room to increase that. So what's happened over the last year to, highlight your role and getting even more people to come forward?
I think the biggest change is that we've been able to get back out. There is absolutely no way of getting away from it. Being able to get out and talk to people is the thing that makes it work. So the 5 drop-ins that we have across the county, so the regular monthly drop-ins, are what's doing it. And what I would say definitely is that the footfall is starting to, we've changed some of the locations, the footfall is starting to really pick up on those now. But what I would say, and I know some members already do this because people tell us, they say, oh, well, Councillor Hunter's told us to come along or phone up or whatever. They are the biggest way. So getting out, being able to be at the places where people are. And I think, again, some of the things I've heard this afternoon about some of the ways of getting people to come to us. So it's all about information flows. How can we draw people to us? I would say, I would look at parish councils, I would look at you in your roles as county councillors. If you feel that if you're hearing things, you can solve the individual problem, but what Healthwatch is about is system change. So the more that you can solve people's individual problems and then either getting people's permission to tell us or get them to come along to us means that we gather that bulk evidence, which then goes up into the system change issue. So I would say it's us getting out and about and hearing more, and it's also us activating and lighting up the networks of people we work with, and definitely yourselves, we would say as key partners to that.
Any other questions? Comments? No? In that case, thank you very much, Derry. It was really interesting, and yes, we'll come to you. Well, certainly I will be coming to you, AGM. Well, thank you. Oh, I think that's a hint. So we'll just move on the agenda then. Where am I now on this agenda? I've written so many notes. The Health and Wellbeing overview and scrutiny, the work programme. Chris, can you take us through the work programme, please?
Thanks, Chair. Just to make members aware that there's an item on the agenda for next meeting on the 4th of October, which is the Adult Social Care Market Position Statement. That's being deferred to the November meeting. But other than that, the work programme is up to date, and as always, if members have anything they want to add, they just need to contact either myself or the Chair.
Okay. Councillor Hill?
Thank you. I don't know if it can be dealt with now. I don't know if there's anyone in the room can help, but I was asked about the progress of the Berwick Hospital. There's been delays with the archaeology, some quite significant findings, and haven't heard any really recent communicate or specifically tied down about timescales. So would we be able to ask for an updated timescale where we're at?
I will speak to the trust and get an updated timescale, but there'll also be members of the trust here at the next meeting. So we might be able to put a short item on the agenda to bring that then. Yeah.
But if you get any information before that?
Yeah, if I get anything before the next meeting, I'll definitely share it with the members, yeah.
Reported. And I'm looking round, nobody's going to jump. So the date of our next meeting is Tuesday the 4th of October, again at 1 o'clock. And thank you all for attending. It was a long meeting, so thank you very much for your patience.